Today I thought I'd talk about macular degeneration. I do quite a bit of macular degeneration work, particularly at the public hospital, because I'm the lead of the injection service there, so we're doing sort of 8 or 10,000 injections a year at public hospital now, so I sort of oversee that and hopefully make sure they're done safely and appropriately and we're doing all the right things. So that's where I kind of do a lot of this work, a little bit here as well, but I'm a vitreoretinal surgeon at heart, and I've got to halfway through show a bit of that as well. So I thought today we particularly concentrate on the Amd Basics and Classification, particularly classification, because that's a really important part of working out the prognosis and some of the management things. And then talk a little bit about current AMD management, particularly about some of the controversies and some of the new stuff, just to kind of and set the scene a little bit with some of what we've been doing before, and a little bit about some of the future developments, particularly some of the studies we're doing now here for geographic atrophy. So for the basics, so as I'm sure you're all aware, it's AMD is the leading cause of blindness in New Zealand, and it's a complex disease, and there's lots of environmental and genetic risk factors, and some of them are modifiable and some are not. So age is the strongest non-modifiable one. So I like to tell my patients that they're sort of privileged to be old enough to get the disease and try and find a sort of positive for them having it, or they've had too many birthdays, all these sorts of things, but nothing really helps sort of say that it's because you're getting older that you're getting this disease. So if you're 55 to 60, there's about a 3% chance of having AMD, and by the time you get to 80, it's nearly 20% chance, so it just goes up sort of steadily during that time. And family history is important, so it's the next highest non-modifiable risk factor. You can't, unfortunately, for some people, change your family. So that's about a twofold risk if in a first-degree relative. And that ties in with the genetic stuff. Of course, you inherit some genes from your parents. There's about 34 genes involved in AMD, some protective, some give you more risk of the disease, and it's sort of complex how they all interact. So it's a bit complicated to work out how that all turns out to whether you might get AMD. But as we'll talk about later, complement genes are particularly involved in the pathogenesis. And the one big modifiable one we've got is smoking. So you have a 2 to 4-fold risk of AMD if you smoke, and you probably get it about 10 years earlier than normal. So that's the big modifiable one. So I wanted to talk about dry AMD first, and I didn't really want to use the term dry AMD because part of the classification is that we shouldn't really be using that, but I thought it would be better to start that way because that's how we talk to patients, and then we'll try and by the end of the talk not say dry AMD anymore. So this accounts for 90% of macular degeneration, so it's more common than the neovascular AMD, and it's slowly progressive, so people might notice, trouble in dim lighting, small print. I'm sure you see lots of patients like this in your clinics. And you'll see signs of drusen, some pigmentary changes, and also some areas of atrophy. And so the pathology that you're sort of seeing is demonstrated here. So you get a thickening of Bruch's membrane, which is between the RPE and the choroid. You lose your choriocapillaris, so the little blood vessels below the Bruch's membrane disappear, and then you get little drusen accumulations of these little waste products. RPE lifts up, and then you can get some atrophy of the photoreceptors overlying. So, and that can steadily progress to the stage where you get big areas of atrophy, and that leads to visual loss. So classification of AMD is sort of the main focus of the talk, really. And if you take anything home from it, probably this is the one thing that I'd get you to try and remember. And so this is the Beekman classification. There's a few different ones. They all are roughly the same, but this is a group of very well-educated retinal specialists have all come together and decided what's important, what's not, and come up with a classification system. So it ranges from no, AMD with these little things called druplets, through down to medium drusen and no pigmentary changes. And that's the size there, which we'll talk about in a second. That's early AMD. Then we go to intermediate, where you've either got large drusen or you've got any of the previous drusen, but you've got these sort of typical pigmentary changes. And then you go to late AMD, or in some cases people would call it advanced AMD, and then you have neovascular or geographic. So dry is not anywhere in that. It's AMD all the way, and then when it's advanced you get geographic atrophy or neovascular. So that's sort of the terminology that we should try and use. So this druplets thing I thought was quite interesting, because druplet sounds quite cute. I was like, I wouldn't mind having a couple of druplets. I thought probably someone's just made that up, but this is a cute little guy with drupelets. So drupelets are the little bumps on raspberries. So a drupe is a fruit that has a stone inside it like an apricot. And if you have an aggregate fruit like a raspberry, all of those little drupes are called little drupelets. So all those little bumps on a raspberry are drupelets. So that's apparently where the term comes from, which I thought was quite cute and interesting. So how do you know the size? Well, the way to tell the size of a drusen is the retinal vein that leaves, the hemiretinal veins that leave the disc are about 125 microns. So if a druse is bigger than that, it's large. If it's half the diameter or smaller, it's a druplet. And in between is a medium-sized drusen. So that's how you know the size. And why is that all important? Well, if you look at this table, this is from the ARED study, which we'll talk about a bit later, but essentially it's got in here different size drusen and whether they're on one or both eyes, and then whether you've got these pigmentary abnormalities from either none, one or both eyes. You can see if you have only small drusen or druplets, I just like saying it, and or just intermediate drusen, but you don't have pigmentary abnormalities, you've got really a low risk of developing, this is late advanced AMD with visual loss over, I think it was 5 years this study was done. Whereas you go to the other end of the scale, if you've got large drusen in both eyes, and pigmentary abnormalities in both eyes, you nearly have 50% chance of developing in one eye. So, if you're looking at a patient in clinic and you're trying to work out how worried you should be about them, this can really help you kind of decide if this is a high-risk patient or not. So I like to try and get audience participation with varying degrees of success at these. So what I'd like to do is get you guys to tell me whether these people have AMD, and if they do, whether you think it's early, intermediate, or late. And you can just yell out or however you want to do it. So I've just enlarged the pictures even a bit more, so it's really in your face, just all about the retina now. So does anyone think this patient has AMD? No. It's my retina, so I hope not. So it looks fine to me, thankfully. So that's on an iodine as well. So there's some different photos with slightly different colours and things as we go through from just different imaging devices. So that's no AMD, thankfully. This one is not the best picture, I'm afraid. But does anyone think there's drusen in there? Yes. Yeah. So if you sort of through here, I think this is probably one too, but it's really hard to find a person with early AMD because we don't really see them in clinic. It's just an incidental finding looking at someone else. So I think that might be a medium-sized drusen, in which case it's heading more towards, or even a large, sorry, but because it's about, it's getting towards the size of the diameter of that vein. But if we just pretend that's not there, then this would be early AMD. But it was a bit hard to find a photo that would actually sort of describe that. And for extra marks, is there any other pathology or issue in the back of that eye? Yep, there's a little nevus up here, up there as well. So this is an Optos image from Public, and so did anyone want to describe the image? So the colours are all a bit different with this, and so it sort of gets a bit trickier using different photos and imaging devices. But what do people think this would be? I think the one thing this photo shows really nicely is the pigment changes that you might see. So these little guys here, a little group of sort of hyperpigmented and then sort of hypopigment areas around it. So instantly, with any drusen with some pigmentary change, you can say this is intermediate. But if you look at the size of the retinal veins again, and then you look at these are drusen, they might not look quite as obvious. Some of the colours might make them look a bit different, but they're sort of a bit calcified ones as well. So these are definitely large in that too. So they're large drusen and pigmentary changes. So it's definitely intermediate.
Are they in that superior location for any particular reason?
No,
Just random.
Just random. Yeah. I mean, it's interesting. There does often seem to be. If you have a look, a preponderance to be sort of temporal and sometimes a little bit more superior, but I don't think there's any particular reason for that, not that I'm aware of anyway. So I said intermediate. And obviously that classification system, it's not about OCT, but we're getting OCTs, and so you're seeing that too. So this is an OCT from that patient. And the sort of things you might see is sort of a Druzanoid pigment epithelial detachment. So your RPE comes along here and then just bounces up with sort of a bit of hyperreflectivity inside it. And these are some smaller drusen out here as well, some of those sort of calcified sort of other ones you saw further out. So this, this patient would still be seeing well because they've still got their ellipsoid layer that runs nicely over the tops of the photoreceptors, still look healthy and intact. And another one. That's me again. This is an optos image of my eye. So so again, there's no AMD there, not even droplets, not even one or two little cute droplets. And what about this? What do you think this one is? Yeah, so this is geographic atrophy. So what gives it the appearance that makes it look like this, so sharply demarcated? Why does it look like that? What's missing? What's missing there that's present everywhere else? RPE, yeah. There's probably a little bit of RPE left in that kind of funny shape thing there. And so what are these? Just the choroidal vessels, yeah, that's right. So sometimes you think there might be like a new vessel or something like that, but we can just, because the choriocapillaris is gone and the RPE is gone, you're just seeing those large choroidal vessels really clearly. And you can see the choroidal vessels, here in a pale fundus a little bit, but obviously they just become so much sharper when their RPE is not masking them. So yeah, that's advanced with geographic atrophy. And again, OCT is not the focus, but this is a different patient, but on an infrared image you get that sharply demarcated loss of RPE, which on OCT in this case the RPE is missing from here. You can see this bright light here and here. So as the laser light from the OCT shining through, you actually see the choroidal vessels really clearly here, just like you could see them clearly on that picture before, because you're not getting absorption of the light from the RPE that's missing across here. And in this case, then you've lost the outer retina through this area, so there's no photoreceptors here. They start again over here and here. And here, you've lost all the retina. There's actually nothing at all right in the centre of this one, so you could arguably call it a macular hole, but it's not the kind that you would have surgery for or anything like that. And on autofluorescence, this is what you would see in that same patient with a black area. So the autofluorescence, that grey-white picture you get, is from lipofuscin in the RPE. So if you have no RPE, that area looks completely black. So what about this? How would we grade this one? What size of the drusen compared to the vein? It's probably a borderline, isn't it? What do you reckon? Do you reckon they're large or medium? It's a bit hard to tell. I guess if that was one, it would be large, wouldn't it? But are they two separate? So it's not, it's not that easy to tell sometimes. But I have decided that it was intermediate. I thought that was perhaps large enough there, but there's no pigmentary changes. But again, the drusen do seem to be that sort of temporal location. And one more, right eye. What do you guys think for this one? What sort of size drusen can you see? Definitely large, aren't they? Large. A few of these are probably large. And again, pigmentary changes. I'm not sure. I mean, there's little drusen in here with which alter the pigment there, but there's sort of not that sort of hyperpigmentary or sort of speckled thing you might see. So I don't think there's any pigmentary change there. So back to this guy again with the nevus. This is from 2010, and again, if we perhaps call that a droplet, or imagine it's not there, then we decided this was early AMD. It's not the best picture either to tell, really. So if we fast forward 5 years, we've got a better Canon camera at the public hospital at that stage and a nicer picture. I don't think the cataract's been removed. So we know it's the same person. We've still got this freckle. I'm not tricking you. So what do you think? What grade would we be now? Yeah, I think you've got. Yeah, we've got this guy here is perhaps a large one. If you look at, I mean, they look quite engorged, almost veins, really, almost, or they look large. But I suppose they're comparable to the arteries, and it is a highly magnified photo. But yeah, you could argue that might be a large. I don't think there's any pigmentary changes, but there's certainly a lot more drusen. So I think I called that intermediate based on that large druse, and this is from diabetic screening, so there's a little microaneurysm or a little dot hemorrhage there as well. And then 5 years later, it comes back again. And so I think it's clear now that this, if it wasn't a large druse, it certainly is now, and this one would certainly be large if you compare the size. And you're sort of seeing that more, there's lots more sort of drusen becoming visible kind of all the way around here. Now, maybe that's partly the camera. This is eyed-on now, so it might partly be the camera, but you can see there's sort of a speckled kind of reticular pattern all the way around, and you can sort of bet your bottom dollar that there's unhealthy kind of RPE kind of all the way through there, and, you know, maybe one day he might be one of these unlucky people where this turns into a big sort of atrophic area.
Is that some hemorrhages?
Yeah, so that's again a diabetic hemorrhage, yeah, probably here and here. As I said, these photos are from a, well, this is AMD incidentally kind of picked up on diabetic screening. So intermediate. And I still don't really think there are pigmentary changes, just the large drusen.
So, can I ask,
Oh yeah, please ask questions. Yeah.
Beekman, where I saw it said large and pigmentary changes. Are you happy to call it intermediate just based on the size without pigment?
So large drusen so you can just have a large drusen by itself or any pigment. So if you have medium drusen but there's quite a bit of pigment change, that would still count as intermediate. And so that last patient, which we sort of followed through over time, the other eye actually had similar findings, but there was a bit of pigmentary change, but it wasn't a good photo, so I didn't show. So, you know, he's probably in this category of, you know, 1 in 4 chance of developing, you know, significant atrophy or neovascular AMD over the next 5 years. So, you know, he's heading towards that sort of higher risk category for sure. And so we've talked, so I guess we've hopefully gone through this and gone through no AMD early, although slightly fudged that one, definitely a lot of intermediate, and we saw at least one case of geographic atrophy. So now we just want to talk about neovascular AMD, which is obviously the other kind. So again, we're trying to avoid saying wet. It's later advanced AMD, but this is just neovascular AMD. And it's about 10%, so it's much less common, but obviously it's generally much more severe. And so if you left someone with neovascular AMD untreated, about half of them will lose their vision in 6 months, and by a year it's about 75% will have all their central visual loss. So, you know, it's a much more rapid and generally symptomatic condition, although I'm sure many of you have found people have only come when they've lost vision from neovascular AMD in one eye, and then they realise that they've actually got a scar in the other eye and they just never knew. So that's where the old Amsler grid comes in. So, I just popped back for a second. So, this is just, again, talking about the pathology a little bit. So, obviously, we've got those AMD changes occurring with drusen. There's microscopic inflammation going on down there in the RPE and Bruch's membrane. And part of that inflammatory process leads to VEGF being produced, so that's vascular endothelial growth factor. And that stimulates these little abnormal blood vessels to grow up from the choroid and up and through Bruch's membrane under the RPE, which these ones are, and then sometimes even up through the retina to the subretinal space. And they're abnormal, they leak and bleed, and I tell patients it's a bit like a healing response that's gone awry. And obviously then that leads to much quicker and rapid visual loss and potentially even fibrosis and scarring if untreated. But that sort of growth of abnormal blood vessels and sort of tissue with it, that's called a choroidal neovascular membrane, and you probably hear that sort of sometimes in letters and things that people talk about. But it's not the only cause of choroidal neovascular membrane, so I thought I'd just briefly talk about that. So, almost all that we see is AMD, but we see it sometimes in high myopes, anyone with inflammation who has sort of scars for some reason, trauma with scars, and then sometimes it can just be out of the blue as well. So any of those things, what you're looking at is disruption of the RPE and Bruch's membrane through scarring or trauma or some mechanism, often associated with inflammation. And so it's the same sort of processes, and it just drives these blood vessels to grow. And they can get, if it's obviously near your macula, you can get, certainly run into visual problems as well. And so just to show a couple of those kind of things, does anyone want to say what looks kind of abnormal on this photo? Again, it's a optos image, so it might be, colours might be a little bit off to you. What does anyone know? Yeah, what does anyone know what these things are? One there.
Streaks.
Yeah, angioid streaks, that's right. So this patient has angioid streaks. She's got Pseudosyntholasticum, which is a connective tissue disorder which affects all tissue, but particularly Bruch's membrane and the RPE can be affected. And if you look at her autofluorescence, you can sort of see them a bit easier, and see there's actually a lot more going on than the colour photo. So she developed a choroidal neovascular membrane in this eye and had treatment, but unfortunately she ended up with sort of significant atrophy. So these dark patches here are sort of quite significant areas of RPE atrophy. They don't look kind of like GA as much on that colour photo, but that's essentially what they are. But all around her disc and right through her macula, she's got normal hyper autofluorescence and sort of patchy hyper and hypo through here as well. So it's a diffuse problem with the Bruch's membrane rather than just what you see on those angioid streaks. And one other kind of secondary choroidal neovascular membrane. Can anyone describe sort of what they're seeing the macula on this? Okay, so what the cause of there'll be a choroidal neovascular membrane there, but what do you think there? It's actually a bit unfair because it doesn't really look. This is a myopic CNVM, but you wouldn't look at that fundus and say it's particularly myopic, would you? There's no big PPA and it's quite dark fundus, but she's of Indian origin. But she's -8, and she presented with 660 vision and this whitish kind of area here in the retina, and these sort of funny rings around it, which is edema, which is easier to see. So she's got a myopic CNVM, and which is easy to see on her OCT. So if we look here, she has macular edema with intra-retinal fluid, the cystic stuff here. And then on this one, clearly she has this little bit of subretinal fluid as well. So that's the RPE there, in this dark space is the subretinal fluid beneath. So a combination of both. And again, just more out of interest and just showing off some of the technology we have. And this is from public. This is a fluorescent angiogram, which we don't do very often now. But because she was young, she didn't look too myopic. She didn't have lots of lacquer cracks or anything like that. It was a bit unusual. We wondered if she maybe had a scar or some other kind of pick or something else previously. But anyway, all she had was this little hyper fluorescent lesion here, which looks sort of lacy and perfect, and that's just this little frond of blood vessels, and we'll see a few other fronds of blood vessels in a minute. So that's the actual choroidal neovascular membrane, little sort of fronds coming out from a central stalk. And this is OCTA, which isn't too impressive on this one. I've got some better examples, but this sort of abnormal wiggly mess of worms here, it correlates on the OCTA scan, OCTA geography, to this area here. But I've got some better examples to kind of show how they match up. So would anyone like to describe what they see on this image? It's definitely not normal, this one. What do you guys think? Do you think these are Druzin? Exudate, yeah. They look more like exudate, and sometimes people ask why, and I don't know why, but they look more like exudate. Part of it is they're linear, they're sort of streaky and long and thin. You don't really get Druzin that look like that, and they're a slightly yellower colour. The other thing about them is Druzin are deeper, so they sort of are less clearly defined. These, again, the photo quality, that's very enlarged, but these are quite well defined and sharply demarcated, whereas Druzin, which you probably can't even see any Druzin here, that might be a Druz there, are sort of a bit less well defined because they're deeper down. And so obviously we've got retinal hemorrhage here, and then there's this funny greyish kind of thing all through here, and then there's some pigmentary change here, which would indicate sort of long-standing AMD with some Druzin around. So if you put it all together with exudate, hemorrhage, this funny thing, and some background AMD, then this is going to be neovascular AMD, isn't it? So this is the OCT for this patient, which isn't the best quality, unfortunately, but what we can see here is a few of the things we see on the colour photo. So we see the RPE coming along and then lifted up here and then dropping back down here, and then there's still another line here, that's Bruch's membrane still sitting there, but the RPE is lifted up. So there's fluid and the abnormal blood vessels, they're sitting inside that PED. And then above that we've got edema, so there's some intraretinal cysts here and just sort of generalised thickening, because if that's normal thickness, that bit's also sort of thickened even though there's no obvious cysts. And then there's probably a little bit of subretinal fluid on this side. And these are some of those bits of exudate. You're seeing those very hyper reflective in the retinal layers. And then I've tried again to marry up with varying degrees of success the OCTA with this picture. There's one better example of this, but this one's a bit better. But it's got a bit grainy because we had to blow it up. So this is the abnormal. So the OCTA takes slices through the retina, and so you have to look down to quite deep in the retina, and then you see these abnormal blood vessels that shouldn't be there. So all the superficial retinal vessels are all gone out of this picture. They are more, they're sort of here in the slices, and we've moved back, and then we've looked down near the RPE and seen this big sort of wobbly frond of blood vessels. Now probably it sort of comes all the way around. That greyish area we saw on the picture, in fact, go back to it, is probably all the abnormal membrane and blood vessels. So it probably stretches all the way around here, but we can only see, did I go back and do it again? No, I didn't. We can only see, you know, a small portion of them on that. And if you did a fluorescent angiogram, you'd see leaking from there, but you wouldn't see those blood vessels as well because they don't show up as well when they're under the RPE on a fluorescein. The myopic lady, her membrane was under the was in the subretinal space, so it's much easier to see on the fluorescent angiogram. And this might be one of the final ones. So what's happening at this macula? Hey?
It's a bit buggered.
It's a bit buggered, exactly. So this is obviously a neovascular AMD, but it's all putted out. We don't see any hemorrhage or obvious edema or anything, but there's a scar here. So this is, you know, a disciform macular scar, I suppose, or certainly fibrosis right at the fovea. So, you know, poor vision in this patient, and their OCT looked like this, which is again sort of, I guess, a PED. It started off life as a PED under there, but it's probably now sort of fibrosis, and maybe there was some blood, subretinal blood there that's all fibrosed as well. And you've sort of lost your normal retinal layers kind of coming along here, the outer retina, and then they sort of disappear through here. So there's overlying this, there'll be no, you know, normal photoreceptors or anything. And there's a funny little thing here. This is called an outer retinal tubulation. So there's a little dark patch with a hyper-reflective kind of outer layer. So sometimes that can be confusing. It looks a bit like swelling, but it's actually sort of a degenerative change. It only occurs in like really atrophic bits of retina or over these scars. Okay, this is the good one. Right, so this patient, they're going to have neovascular AMD because that's what we're talking about. So, but it's not that easy to tell. I'll blow it up. This gets really big, I think, this one. Let's have a look. Because there's no hemorrhage. Maybe these are some drusen. And there's certainly these are sort of classic sort of pigmentary changes that you would see. So, you know, if you looked at this, I don't know, you might think they've got intermediate AMD, I suppose, but they've come with, let's say, distortion and slightly worse vision than you'd expect. Can anyone see anything else abnormal on the picture? Optic yeah, it doesn't look that good, does it? But I think it's actually fine. It just looks really bad on this Optos image. It's not as bad as it seems. There's this funny thing here, this wiggly thing here. So so it looks a bit like choroidal blood vessels, because obviously we talked about that before. You could see them in an atrophic area, and you could see here's these big choroidal vessels here running around here. You can sort of see them down here a bit better, but where there's a bit more pigment here, you can't see them as clearly, you know, naturally anyway. But this is quite prominent, and this is a bit funny. It doesn't look like sort of the normal branching choroidal vessels. So if you do an OCTA on this, this person actually has neovascular AMD, and so if you're doing it now, this is what I spent ages trying to line this up. So be impressed, please. So that's this abnormal blood vessel. That's, you know, it's basically this big trunk coming up from the choroid and then squiggling through the retina, and because it's all kind of in one layer, we can get it really clearly on the OCTA. So I did this a couple of times because I thought you definitely kind of want to see it again. So as it goes away, you can sort of see it just fits that really, you know, bendy shape there. So, you know, this is actually seeing those blood vessels deep down under the, you know, under the retina, which you know, we didn't used to think you could see at all. And I think it looks a bit like Medusa's head with sort of all these like little snakes coming out. So that's enough looking at those things. And so when would you refer someone? So I guess I thought about it, and I suppose it is a bit different, public and private to some degree, but not for neovascular AMD. So if you think someone may have neovascular AMD, so, you know, their OCT suggests that they've got a new hemorrhage, you know, someone with pre-existing AMD who's just got symptoms of distortion, then, you know, regardless, they would be seen very urgently, publicly or privately. So the public hospital would try and see them within 7 days, and certainly that would be what we'd do here as well. And there's good evidence that if you see people as soon as possible, and certainly within 7 days, and give them an injection, they do a bit better than if they wait, you know, weeks. But obviously, sometimes they've waited a long time before they've come to see the first person. So regardless, you know, generally people getting quite quickly. You might tell me differently if the referrals to the public hospital aren't getting through, but generally they're triaged each day and seen pretty quickly. And in fact, they're taking over the whole eye department so much that everything else isn't being seen, and that's why, you know, that's really all we see on AMD now, and we don't really see your intermediates and even your atrophic patients as much, which is a bit of a shame, but I think you guys are very capable of looking after them, and probably better in some degree. And but, you know, in private, of course, if someone needed a second opinion, one of those lower level AMDs, or they wanted, you know, there's questionable findings, or they're a bit young and you wondered if they may be a different diagnosis, then obviously you can refer people with that. And then also we've got some trials running here about geographic atrophy, and so I'll show that at the end, but if maybe someone was a potential candidate for a trial, then that might be another reason to refer them through to us. Oh yeah, so I got a bit sick of AMD. So, and I do retinal surgery, so I thought I would show this picture. What's wrong with this person's eye?
It's got something in it. That doesn't belong.
Does. That's right. So that's a bit of metal. So this guy's, he's about a 50-year-old. He was doing some DIY. He was hammering crowbar and breaking up concrete, and just felt something flick into his eye. And then over the weekend, he saw a few floaters. And then he presented to the eye department of public and found this. And so this is, yeah, a little shard of metal, which looks like it's sort of embedded and sitting in the retina, because it's sort of got all this whitening around it, and this all looks like it's gone through and just sort of, you know, smashed into that. And you see this pale area around it, which is sort of this toxicity of metal that you have with the retina. It gets this sort of pale appearance, and the blood vessels kind of clamp down a little bit, and it looks a bit unhappy, and a few little hemorrhages too. And so head wound, I'll actually show you the video. This is this is a video of his surgery. So the setup is we're doing a vitrectomy, we're going to, and so he had a little entry wound here. It's just a little bit edematous here, you can't see, but it just was a little self-sealing wound, so I just went in quickly, and it's often the case if they're small enough, they just go in and they don't leak. It's obviously had to have gone through some things, so it's gone through his iris and it's gone through his lens, and so he's got some early posterior subcapsular cataract there. And so we've made a little port to get into the vitreous here. This is an infusion port with fluid going in. I'm just going to put in the last port so we can get into the back of the eye and get going. So hopefully that will... And this is sped up a lot, just so you can't see me sort of shaking as I do things, and or it looks like it's all shaking, and it's slow otherwise. So that's just the last port going in, and then so now we're looking through this lens into the back of the eye. So we've got disc here, the macula's over here, and that's the bit of metal. And so the vitrectomy probe's coming in, and we're just starting to remove a bit of vitreous. You can see things sort of wobbling around a bit with a little bit of metal if you keep your eye on that. And I thought I want to see the vitreous a bit better because I need to make sure there's PVD and clear all the vitreous. So that blue dye is just to help see that. And we're usually using that to stain, you know, membranes and things. So now I'm just aspirating and not cutting and trying to lift the vitreous off the posterior pulse. You can sort of see it lifting up there, and then a bit of metal comes up too, so it's quite cool. So we know we've induced PVD, and we can get the vitreous all from around that, because you can't just drag it out through all of that. And the blue is quite good because you can sort of see the vitreous as we're sort of cutting and aspirating. And it's interesting here, you can see when I do this next maneuver that actually that white stuff, which looked like it was kind of on the retina, is actually just sort of inflammatory stuff in the jelly. So when I lift that up, that comes too. And in fact, in a moment, we'll just do a bit more vitrectomy. You'll sort of see, so you're being careful because that's a sharp little thing doggling around in the eye. I'm trying not to like get it to go over and cut blood vessels and do all other stuff, which you have limited control over to some degree. But now you can see actually that it's free off the surface, and where it was sitting, there's that white area. There's no hemorrhage. It's just like someone's placed it, you know, gently onto the retina, rather than it going to hammer in and create like any sort of damage. So. And you can see it was completely free there. So we finished the vitrectomy, removed all that, and now we have to make a bigger opening here to get it out, because those little it's about 3 millimeters length and probably about 1.5 wide. So this is a 3-ish millimeter wound to get into and get out. So we're going with a pair of forceps, and thankfully, look at it, it's gone set right onto the fovea, just where you'd want it to sit right. So I'm just going to grab that, thanks. Look, there we go, it was quite good. And then pull it out, and then the moment of truth. So as it comes out through that wound, you can always drop it again because you're sort of trying to squeeze it through a tight thing. So this is the bit you think, is it going to come? Am I going to drop it? What's going to happen? It's like a magician pulling a rabbit out of a hat, and there it is. So good. And I found out you could do this on my, I thought we'd see it again, so in slow motion as well. Here we go.
How long did that take? How long did the procedure?
About an hour. It was because there was no other damage anywhere else or anything. It was quite quick. I mean, he's going to do surprisingly well given that injury. So yeah, about an hour. He had a general anaesthetic for this because you can do it under local, but he's a bit younger and a bit nervous about it, and we didn't quite know what we'd find. So we just stitched up the little opening, or the biggish opening there. These ones didn't need stitches. We put an ear bubble in, and that's how we looked at the end of the case. And then this is his Optos image. I think I blow it up from a week post-operatively. So that's the ear bubble disappearing in his eye. And that's the area where it was sitting, and you can sort of still see there's perhaps a bit of sort of funny atrophy, RPE kind of change here, and there probably will be a little bit of damage just from the toxicity of the metal, but no retinal breaks, no detachment. So he was 6.6 vision when he came, and he's I think 6.9.5 because his cataract's a bit worse, but he will end up needing a cataract surgery, which will be a bit tricky because the capsule will be damaged. But I suppose very unlucky for it to happen, but quite lucky how it ended up. So that was just a bit of a break from AMD.
So what were his symptoms? Was it just floaters?
It's a couple of little floaters, yeah. It probably just a little change in the vitreous, that was all, because and he thought his vision was down a little bit, but that cataract it was still just off axis, so he was still 6.6 vision, and I think his wife had to convince him to come, as often as the case. So management of AMD is the next part. So the first few things are things you can obviously you can tell any of your AMD patients to do, or even family members of AMD patients who are worried about it. So we said smoking is the biggest modifiable risk factor, so 2 to 4 times the risk 10 years earlier. So getting someone to stop smoking is the biggest thing you can do. It's not that easy, obviously. So I tell people to go to Quitline, and they'll offer you all these different ways of getting help. You can text, you can phone, you can go on Facebook. And they've got 24-hour support and counsellors, and they have subsidised nicotine patches and all those things. And so there's definite evidence that if you use Quitline and use some sort of replacement, that you're more likely to quit. And we're in a privileged position because if you show someone the back of their eye going bad and say, might help if you didn't stop smoking, sometimes they're a bit more likely to listen. So that's always the first thing. And then diet. So our patients always sort of say, what do you mean by eat a healthy diet? Because that's often what kind of you say to them. And I guess, that's a good start. Lots of fruit and vegetables, essentially lots of antioxidants. But if they ask me, sort of specific things, I tend to say, I guess that's why our parents told us to eat our greens, because spinach and kale have lots of zeaxanthin and lutein, which are pigments in your macula. They're antioxidants, and you need lots of them, and they're in the A-reads vitamins. So peas and broccoli have them as well, but they're the highest of those. So I say eat a bit of that, and you can chuck spinach in just about anything, and it doesn't taste anything, so it's pretty easy. Oily fish. So the ARED study didn't show that omega-3 helped in addition to those vitamins, which we'll talk about in a minute. But if you look at big populations, if you eat more fish, you have less AMD. So there's still a suggestion that recommending salmon or things like that once a week or something is quite helpful. And then nuts are a bit of a superfood, and they're usually quite nice to eat. But you're only meant to have like 30 grams, which is quite a small amount. It's hard to stop at 30 grams, I'd say. But they have good fats, good proteins. They've got your vitamin E, all the stuff, basically all the stuff that's in the AREDS vitamins. So I suggest those 3 things to people if you want to do something a little bit extra to help your diet. And the old AMs, the grid, as we talked about, one of the problems is people just come with only when the second eye goes bad for some reason, or they come too late. And certainly with the neovascular AMD, the earlier we get onto it, the better. So as much as anything, this is simply just the fact that you're getting them to cover each eye and have a look through each eye, which in most day-to-day life no one ever does. But obviously, you guys know how to use these charts. But I mean, everyone with AMD should have one of these and be asked to use it occasionally. You just have to watch your patients because some of them get paranoid and want to check every day, and I suggest that's probably a bit too frequent, and maybe just every few days, or if they feel their vision isn't quite right. So the vitamins, so the age-related eye disease study, and you probably have heard a bit about this, but there was 2 studies, one done a few years ago where they gave all of these things, but they gave beta-carotene, which is a different antioxidant, and it showed that it reduced the risk of progression to serious AMD in people with intermediate AMD. I'll talk about that again in a minute. But they found that the beta-carotene was a risk for lung cancer if you were a smoker, and obviously quite a few people with AMD are smokers. So they switched it out to lutein and zeaxanthin. And again, in the macular pigments, they're basically to prevent oxidative damage, which is sort of what all these things kind of do. And basically they had the same results, that it was still worked, but they had the safety thing because they didn't have the beta-carotene in anymore. These are just a few different brands you can get. For this, you need both of these. For these, you just have one of these tablets. So these studies had thousands of people followed for 10 years, and they showed either 19 or 25% reduced risk of visual loss. So going from intermediate to geographic atrophy or CNVM. If you took these, but it's hard for patients. They take them, they don't feel better, see better. In fact, the vision may still slowly get worse, but it's the best thing they can do. And unfortunately, they're not subsidised, as you guys will know. One way of thinking about this is you need to treat 4 people. If it's a 25% risk reduction, 4 people for 1 to benefit, which isn't so good to tell the patient, so I try not to tell them that. But a number needed to treat to get benefit of 4 is actually really good. Like, it's better than a lot of the medications that like omeprazole and all these other things that we give out, like, well, not me anymore, give out like lolly water. This would actually be a really useful thing. And there was talk about funding them at some stage, but it sort of went by the wayside. It's strongly recommended, but again, it's only recommended for these intermediate AMD. So it's the only thing that has evidence for. Now, if you take it in these stages, it's fine. You're not going to cause any problem. You'll just lose a little bit of money, and you're probably just peeing it down the sink. Not the sink, toilet. Money down the sink. I shouldn't mix my metaphors there, should I? But the intermediate AMD people, they definitely benefit. So that's the ones who we should be recommending it for. And so then, well, why can't you just use your diet to sort that out? But the problem is that, so to get this, I suppose if you like oysters, it's okay. You have to have 10 oysters, 7 oranges, and 135 tablespoons of wheat germ a day to get that. So there's just no way to get these high amounts in your diet, basically. So the diet's good for those earlier ones, but not for these guys. They can't eat their way to better health. So education and support. So obviously sometimes we can't do much more for their vision, and that's where organisations like Macular Degeneration New Zealand come in. So these guys are a charitable organisation who essentially are aiming to try and reduce the incidence of AMD and the effect, and provide education and support. And so I have these little handouts, and there are some up the back if you want to take one, but I give them to all patients with AMD. And if you join Macular Degeneration New Zealand as an optometrist, you pay a subscription, and then they'll provide this for you to give to your patients. And I just think it's got really good information, and they have these seminars. People can join up and go along and get the information they need. So I pretty much tell everyone about this place, and if you don't have this, you can still just direct them to the website. And then we have Blind and Low Vision New Zealand. So they've rebranded a few times, and they used to only look after people who were over 6 over 24 in their better eye, worse than that. But now they'll take some of the low vision patients as well, and you can fill out forms online to register them, and GPs can register if they've got the right information. And again, they support and counselling, provide aids, and so they're very useful. But especially now that they do help those sort of slightly better vision patients. And we're very, very lucky in Christchurch, I think, to have the Buoyant Low Vision Clinic. So, and I've said visual rehabilitation for this, but they obviously provide support and all these other things as well. And they really do bridge that gap before you get bad enough to be registered with Blind and Low Vision New Zealand. So they'll see people 6-12 on or earlier, potentially, if in a case-by-case basis. And they're great. They provide education. They provide access to all of these different devices, magnification devices. Some very cheap, some very expensive things. Trials and all of this stuff. So, and the other great part is also having the occupational therapist go out to people's houses, which is amazing service to give people some help in the practical things about dealing with their poor vision. So again, I make use of their services because they're fantastic. So neovascular AMD. So I was going to perhaps talk about some of the old treatments for AMD, but now essentially it's just doing this and doing this and doing this. So it's just injections of anti-VEGF because the other treatments didn't really work, or they sort of fell out of fashion, or they just don't compare to the efficacy of these treatments. But we have these anti-VEGF agents. So we talked about, vascular endothelial growth factor is overexpressed in these eyes, and that causes these blood vessels to grow and they become leaky. And so all these do is kind of block that process. And so you'll be familiar with all the names. We've got Avastin, which is the one that we use as a first-line agent for everyone. And then in 2018, Eylea was approved for patients essentially where Avastin fails for certain conditions. And then Lucentis we also had for a while too. And what you see is this is a monoclonal antibody. So basically it binds VEGF and sort of deactivates it, stops it from being able to do its job and make the blood vessels grow. This is the same, essentially it's just that one little part of it, so it's smaller, and the company who makes this, and they made it smaller thinking it would cross the retina a bit better and be a bit more effective. And then this one's quite different, it's a fusion protein, so instead of binding VEGF, VEGF binds to it, so it's like a dummy receptor, and the VEGF binds to it in preference to the normal VEGF receptors. So, and it also binds a few other different isoforms of VEGF, not just the VEGF-A, and some other things that are sort of involved in AMD pathogenesis. So, so theoretically, this should be the best, maybe the second and this third. But if you look at all the studies, they're equivalent in terms of visual outcomes, safety, and everything else, and it's thousands and thousands of patients, multiple studies, and even in diabetes versus AMD, they're still all essentially equivalent. There's always subtle differences, but certainly nothing clinically significant. So the only difference is the price, and we don't really know what these cost because it's all sort of hidden behind sort of pharmac things. But essentially these are at least 10 times the cost or more, and when they first came out, they were more like in the $2,000 mark. And the reason they're different is this little vial is one dose, and this little vial is one dose for one eye, and this vial is 100 milligrams, so these are like 2 milligrams each. So you can get 40 or 50 doses out of an Avastin vial, so that gets sent off to a compounding pharmacy, they draw it up into 40 syringes and then ship that off to us. So that vial costs the same as those vials, but we get 40 doses out of that one, so that's the difference. And it makes a big difference. So Australia they only use Lucentis and Eylea, they spent nearly $400 million on those two agents a few years back now. It's sort of old figures, and that's half of our entire pharmac budget for New Zealand. So we spent about $4 million on Avastin and a little bit of Lucentis, which was a second-line agent back then. So, they're spending, I think I worked at about 100 times more, but should be no extra benefit at all. So there's no real reason why they do that, apart from Avastin isn't technically licensed to go in the eye, although it's given everywhere in the eye. Have you guys seen anyone have an injection? You'll see videos. Does anyone want to see it, or can skip it?
Yeah.
Skip it?
No, I see.
See it? Okay. So this lady doesn't have AMD, but she has diabetes, and she was nice enough to let me take a video. Hopefully I've turned off. Maybe I have to click on it. Let me just see. Not that one.
Was she late to work?
Alright, there we go. So she's getting a subconjunctival injection of anaesthetic. So she's had eye drops first. So we've numbed the conjunctiva with the drops, and then you'll just see this little blister pop up here, and that's the subconjunctival anaesthetic just going under to numb it a little bit more. So she doesn't flinch. You don't really feel that at all. Some people notice something happening. She's saying that was great, thank you, Dr. Robinson. And then we go on to the next one. Hopefully this will go. So you wait 3 or 4 minutes. So that subconjunctival anaesthetic makes it comfortable, and it's nice to be humane, make it comfortable, but it perhaps is slightly has an antibiotic effect as well. So I think it's quite good at reducing the risk of endophthalmitis, which is what we're worried about. So you waited a few minutes, it should have all numbed now, and you get a little blood from the injection site sometimes. So this is iodine, so this is the biggest thing we need to do to reduce the risk of endophthalmitis, which is what we really worry about. And we usually do it supratemporally, so she's looking down into her left to sort of expose that area and make it easy. And so that's a little marker to measure where to mark. So we're going back 3.5 or 4 millimeters from the limbus, which is through the pars plana. That's safe. We're not going to hit the lens. We're not going to hit the retina. And so I'm just getting a little syringe ready. She's waiting. She's had lots of them, so she's a good patient. And then we just dry the area and pop that in. Didn't flinch. And that's just injecting the medicine. and out with a flourish, and then it's always good when the eye doctor wants to see if you can see anything at all after a procedure you've done, which, you know, when you first do it to patients, they think, what are you doing? But if you give enough volume, you can occlude the central retinal artery and they can't see anything, and then you need to massage their eye or take a little bit of fluid off. It doesn't usually happen with, we only give 0.05 mils, but in some of the things we give 0.1 or a bit more, it can sometimes happen. So then we rinse their eye, because that iodine, if you leave it there, they get irritable red horrible eyes, and then a bit of chloramphenicol ointment, which we give to everyone, and then I tried to stop it at a better place so it wouldn't be a bad face for her, because I felt quite bad, but I didn't do a very good job, did I? Anyway, so that's injection. So how do we use anti-VEGF? And this isn't a sort of main focus, but I just want to talk about this because it sets the scene for the next bit. So there's 3 ways. So initially, when the big studies came out about giving these agents, they gave them every month for 2 years, and they showed they worked fantastically, worked really well, but people had to come every month, and they also saw that a few people, basically everything went away straight away after their 3 injections, and then they were still giving them the injections, but they wondered, maybe, did we need to be doing that for these people that responded really well really early? So the next cab off the rank was doing this PRN one, which was seeing people basically every month, but only injecting when there was activity. So, you know, something that looked like this, hopefully not that bad. And activity could just be a bleed, it could be reduced vision, it could be swelling. And so that worked to reduce your injections, because you weren't injecting every time. You still had lots of visits though. But the problem was that basically you let the disease come back all the time and then go away and come back and go away. And they, you know, you can sort of theoretically think that probably wouldn't be so good, and it wasn't. So the vision outcomes weren't as good as doing fixed dosing. So the next one's kind of a hybrid model of these two, which is what we tend to do. And if you look at surveys, probably about 3/4 of people kind of do this around the world. Where you treat every 4 weeks, that's the maximum, and then once you get past the 4 weekly injections, if everything settles down, you can spread it out, and usually by 2 weeks every time you see them until they get to about 12 weeks. And at that stage, people differ a bit, but generally we just keep the injections going for even more at 12 weeks, because if you stop them, there's a really high risk that it'll come back at some stage and they'll be back to square one, and they may lose vision when it comes back. There are some times when maybe you'd stop and monitor, but mostly it just keeps going indefinitely. But of course, along that pathway, if someone recurs at say 8 weeks, which is the commonest time for them to recur, then you have to go back to square one, start again 4 weekly, and then you might take them to 6 or 7 weeks, and that's where they stay. So then they sort of become, in a way, fixed dosing, but it's their own fixed dosing. You've worked out what they need. You're giving everyone the least frequent injections to keep their vision as good as possible for as long as possible. So you're just working out what each eye needs, each person needs. And obviously they come into it because they might say, I don't want to come that frequently, and you just sort of work out what they want, and you might under-treat. And then when both eyes are going, sometimes you treat one a bit more and one a bit less to try and just marry them up to make sure that they're getting injections on the same day, because they don't want to come every week or 2 for an injection. So treat and extend is what we do here, and it definitely sort of basically matches this fixed dosing. So it's the least number of injections and least visits, because you're sort of spreading out the visits and the injections. And people like it because they know they're getting an injection every time. The PRN one they didn't like because they weren't sure if they were going to get an injection. It made them a bit nervous. So how do we know whether it's active? Are they doing well? Are they going backwards? And these are the things. And the reason to talk about all of this is that mainly because now we've sort of changed our mind a little bit about what macular edema is important and what's not, and really the difference between whether intraretinal fluid and subretinal fluid are bad. So this is an OCT just to sort of set the scene of intraretinal fluid. This is very easy. This actually isn't in the AMD patient. This is cystoid macular edema from inflammation, but it's just really clearly shows these, you know, big cysts, you know, in the inner retinal layers, and it's quite obvious to see that that's intraretinal fluid. This patient, which was one we saw earlier, she's a combination of both actually. She has some subretinal fluid down here, so down right beside the RPE, but she has intraretinal fluid here, which does look a bit cystic. But I suppose if you consider that's the normal thickness of the retina here, then you can see here, even where there's no cysts, and even if you take into account that that might be some subretinal fluid lifting this up a bit, that bit there is still sort of thicker than normal. You can see all those, like this layer is stretched out. There's sort of diffuse swelling in there. And so sometimes it can be quite tricky, especially when you're sort of monitoring for treatment, to tell whether there's a little bit of swelling. You have to go back and compare to previous scans. But sometimes it's quite obvious as well, and that makes life a bit easier. But subretinal fluid is a bit different. So what's the subretinal space? So this is a diagram of the RPE and the rods and cones sitting at the macula. So the subretinal space is basically the gap or potential gap between the RPE, which are cuddling the outer segments here, and the photoreceptors. So basically they can be stretched and pulled apart by fluid, and and you can sort of imagine them screaming and not being very happy, kind of just as they get pulled apart. And there's a potential space here because these are different embryologically to these cells. And so, but that's no good for the photoreceptors generally because, you know, you can see how closely they're attached, and the RPE does a lot of the metabolic activity for the photoreceptors. And so if they're apart, you think, well, that's not going to be good for your vision long term. And just to sort of clarify where this is on OCT, because we're going to look at those. So we've got RPE is this bright white layer, and then this is the ellipsoid layer, which is the inner segment. So this part of the photoreceptors here. So, but essentially, if you consider that layer as the photoreceptors, it's this dark layer here. That's where the fluid comes, and subretinal fluid. So here's two patients with subretinal fluid. So what do you think this patient has? Yep, CSER, and there's no kind of way of knowing, but it's that, you know, perfect dome shape, and it's sort of right at the macula. It's very symmetrical. And then what about this? This is sort of slightly asymmetrical and a bit strange. What do you think that subretinal fluid is? There's a lot more over there somewhere. No, so it's not RP. There's good guess, and that's one of the tricks is finding it hard because sometimes when it's lifted up like this, it looks like that could be the RPE there, and the ellipsoid layer can look a bit stretched and sort of brighter. But what you can see here is the RPE comes along, and it does continue. That's the RPE continuing. So the RPE is still flat, and this is the ellipsoid layer here. That's what actually kind of comes up and becomes this. So this is a subretinal fluid from a retinal detachment. So there's detachment right out in the periphery that's come right in. So this is a macular off detachment. And so what do we know about this fluid? We know this fluid's not very good for you. You know, if you go macular off, and even if I fix you, you often have reduced vision and distortion, and you're not very happy, even if it's just a few days. And if it's weeks and months, you know, you might have 618 or 624 vision. So obviously this fluid's not very good for your photoreceptors. But what about this fluid? We know that these people have quite mild symptoms and a bit of metamorphopsia and maybe slightly reduced colour vision and maybe a mild scotoma, but we can leave that for ages and we don't do anything about it and it goes away, and it's like they never had a problem, or they just have very minor symptoms unless they're quite picky. So what about this fluid then? So this is a patient with neovascular AMD. So just to point out, so we've got the RPE coming up. So this is a pigment epithelial detachment because this is the RPE coming up. Now the reason I know that is because there's just one thin little layer left here. That's Bruch's membrane. So inside that bit there, that's where the abnormal blood vessels are. The choroidal neovascular membrane is sitting in this, leaking, bleeding, and causing this subretinal fluid, which is this part here, which is right under the fovea. So, and so this is this double layer sign. So if you see Bruch's membrane here, you know RPE is lifted up, and if it's a sort of a thin, broad PED, then often that's where these little new blood vessels are sitting in here. So the question is that subretinal fluid like this? Can we leave it, or is it like this, and we want to get rid of it? And no one really knows or knew. What we did know is that you could have subretinal fluid like that and people still had very good vision, like they would still have 7.5 or 6.6 vision with some fluid there. But what were they going to be like in 5 years? Because, I mean, this is a long-term disease. So do we have to keep injecting that, or can we just say that's okay? So some people, very smart people, did look back at some of these big studies which I talked about, where they gave lots of these injections to people and had lots of people involved, and they looked to see how people did depending on whether they still had fluid during the course of these injections. And so this was the CAT study, which is a big American one, comparing Avastin and Lucentis in a treat and extend protocol. But anyway, the main thing about it is really this. There's this graph here and this graph here, so it's all a bit messy. But so this was patients. This is intra-retinal fluid graph. So if you had no intra-retinal fluid, and this is your visual acuity score, this is letters on the chart, so bigger is better. So 68, they had the best vision out of this group. If you had some non-foveal intraretinal fluid, you did okay. And if you had foveal intraretinal fluid, you did really quite bad. You only had 44. So, you know, there's a big difference there. You can see intraretinal fluid seemed quite bad, kind of regardless of where it was, because if you had none of it, you did really well. And so this is the opposite here. We've got subretinal fluid. So in this case, if you had subretinal fluid under your fovea, they're the people that had the best visual acuity at 5 years. And if you had none, you didn't do so well. And if you had, none, you did this like this. And if you had non-foveal subretinal fluid, you sort of didn't do that well either. So in this case, what it's suggesting is that subretinal fluid maybe not only it's not bad for your vision, it may actually be protective of your vision, because some of these numbers are sort of as good as these here. So, but this is all retrospective. They're just looking at old data and trying to work it out. So what happened was they a group in Australia did this fluid study where they did a treat and extend strategy, kind of like we described, and they decided that subretinal fluid was going to be okay. So they had an intensive group. So if there was any fluid, subretinal or intraretinal, they got an injection every 4 weeks as long as that stayed there. And if it was completely inactive, so no fluid at all, then they would extend out. The relaxed group was a group where they said you can have subretinal fluid, at least a small amount. And so if you had only subretinal fluid, no intraretinal fluid, they would extend them out like we would as if they were completely dry. And so this is the visual outcomes here on this graph. The intensive group is the whole line, and the dotted line is the relaxed group. And you can see there was a little bit of difference early on, which probably makes sense because these guys probably got a little bit more, a little bit extra injections early on, but they come together quite nicely. So they're basically suggesting that at least at 2 years, there's no difference if you just leave that subretinal fluid there, as long as their vision's staying good and they've not got other sort of signs of activity. So this really has led to a bit of a change. I think most of the retinal doctors here are now, at least in some patients, leaving some subretinal fluid and saying that's okay, and extending the intervals a bit more, which can only be good for patients because they're getting less injections and less visits. But I guess the key will be what does this do in 4 or 5 years? Is it still okay? It will suggest it probably will be, but they'll do a follow-up study and we'll get a bit more idea. So that's just an update on neovascular AMD, and just the last little part, which was just talking about some studies we're doing here, which is the treatment of geographic atrophy. So as you can see, a lot of that's about neovascular AMD stuff, but this is in the test, by the way. So one of the things that is thought to be important in geographic atrophy and in the early stages of AMD is dysregulation of the complement pathway. So complement's just part of your immune system, little proteins floating around in your blood that help fight off infections or also kill off damaged parts of yourself, damaged cells. And there's a few reasons why it's thought to be involved in AMD. So if you do genetic, we talked about those genetic tests early on, there are some genetic variants, so they're not a disease thing, but some genetic variants in complement genes. If you have those, you're more at risk of AMD. And there are some, if you have different other ones, that you are less at risk, and the ones that seem to make you more at risk are ones where there seems to be more complement or it's a bit more overactive. So if you have some of those, and then you have this normal oxidative stress and sort of damage that you get from smoking and age, you can activate complement pathways, and it's a bit more likely if you have these genetic risk factors as well. And then this is the main complement factor, which splits off and basically leads to a trigger of reactions which create inflammation in the retina. And so we talked about that chronic inflammation, and that's kind of where the damage occurs, and also maybe where VEGF comes into it. So, and the problem is it's a cycle. So if you create a bit more inflammation, you get more damage, which starts this all off again. And so that's thought to be partly why we're getting AMD in these patients. And if you look in AMD patients, they have more complement or high levels of complement in their blood. If you look at their retinas, there's complement scattered throughout it in the areas that get damaged in AMD. So there's good evidence that it's part of what's going on. So if you had a way to somehow reduce your complement system's overactivity at least, then you might find we could help GA patients. So this is just a little video which explains it far better than I can, and it means I don't have to talk for a bit. So hopefully.
Geographic atrophy, or GA, is an advanced form of age-related macular degeneration, or AMD, that leads to progressive and irreversible loss of vision in elderly individuals. AMD is characterized by the presence and accumulation of medium to large drusen, deposits of cellular debris, including proteins and lipids, which appear as yellowish dots under the retina. In individuals with genetic and environmental risk factors, AMD can progress to geographic atrophy. GA is characterized by progressive and irreversible loss of photoreceptors, retinal pigment epithelium cells, RPE, and the underlying choriocapillaris, resulting in the development of sharply demarcated atrophic lesions in the macula. Over time, these lesions can grow, leading to loss of vision. With aging, cumulative damage triggers inflammation via multiple pathways, including the 3 complement pathways. As a result, complement C3, the central protein serving as the master switch in the complement cascade, becomes dysregulated and hyperactive, leading to chronic inflammation of the macula, the opsonization and death of retina cells, and further activation of the downstream complement cascade, which results in formation of membrane attack complexes. This results in a vicious cycle of macular inflammation and death of photoreceptors, retinal pigment epithelium, and underlying choriocapillaris. Blocking complement C3 may help the body regain control of the complement system and potentially inhibit the progression of GA over time. New Phase 3 clinical trials are assessing the efficacy and safety of C3 inhibition in individuals.
So this is a study that's finished enrolment here now and worldwide, and Marie's here, who our study coordinator, so she'll correct me about anything I'm wrong on. But basically, we were involved in the Philly study, which was a phase 2 and earlier study, which showed that it made some difference and it was relatively safe. And so it's moved to these phase 3 where there's bigger numbers trying to work out whether it really does work. And so this APL2 thing is the compound, and it blocks that C3 to try and basically reduce complement activity. And it's directly into your eye. So this is these are intravitreal injections given every month for 2 months. And we have 4 patients, Marie, or is it 5? 4. But there's a lot of work. They get seen really regularly, lots of tests, lots of work from Marie and the nurses and the people and the technicians taking lots of photos and all these assessments. And I just occasionally give one of the injections, which is quite interesting because sometimes I give a sham injection and sometimes I give a real injection. So you just pretend, you just put the syringe against their eye and that's it. And then in the real one, you jab it in. So they don't seem to notice the difference. So what they're looking at is do those areas of geographic atrophy get bigger? And then also some things which is kind of quite easy to measure on those autofluorescence images, those really dark patches, if they're getting bigger, and you can measure how quickly they get bigger. And then some things about vision and standardised reading assessments, like is their reading ability, maintaining at least, or it probably won't get better, but it should at least maintain. And is their vision remaining stable? So that's a 2-year study, so we way to go to get results of that. But it's something that might be possible. That we've got something to treat GA with. Although the thought of having something else to do to inject into people's eyes when we're already struggling just with the Neovascular AMD ones is a bit of a worry. And the new study that we're just enrolling for, and we've got a couple of patients who are being screened for, and there's room for some more, so that's part of the reason I'm telling you guys about it, is this ONUS FB LRX study. And again, another complicated diagram about complement, but essentially this one, it works by blocking this complement factor B, this part of the alternative pathway, and it leaves these ones intact. And that's important because this one is a systemic thing, so it's a subcutaneous injection, so it's not something injected into you. Are they doing the leg or their tummy? Stomach. And so it works on the liver and reduces your complement production made by the liver. That's where the complement is made. And so if you measure in the systemic circulation, they have less complement activity because of this being inhibited, which is a bit dangerous if you were inhibiting it all, because it's often important for fighting off infections. And so even though they suggest that it won't be a problem, you have to be immunised against meningitis and a few other things to be involved in the study, just in case there's some reduction in your immunity. So yeah, the thought is that the alternative pathway is more important than the classical pathway, and by doing it this way, you're sort of reducing the stuff at the source rather than trying to stop it just in the eye itself, and it may therefore work a bit better. But this is just a phase 2 study, so it's just the early stages with smaller numbers of patients, and it's proven that it's relatively safe, and it does lower complement levels in the blood, but we're just not sure how effective it's going to be. So this is one of the first studies to work that out. And it's an antisense oligonucleotide, which is hard enough to say, but it works in a different way to the normal medication. So if you look at how there's a gene that makes complement factor B, and it comes out like this, then you mRNA, and then that turns into a protein, and so in this case complement factor B. And if you've got one that's a bit overactive, or you're making too much of it, you're more likely to get to the disease. And so in normal circumstances, like with Avastin or something, you can have an antibody that binds to that disease protein, or you can have something that blocks it essentially. But this works by getting involved with the messenger RNA, so it actually stops you making the diseased protein, or in this case, this complement factor B. So you reduce that down. So you're sort of not affecting, you know, your normal gene and DNA, but you're affecting kind of the messenger system that turns it into a protein. So that's how this works, which is sort of quite a different way of doing things, and quite clever. So this study is 18 months, but there's just 12 months of active treatment. So they inject themselves if they're good enough, or a nurse will do it for them once a month. And there's quite a big screening program to make sure they're safe and okay. And then after that 12 months, we'll see whether there's been any effect on the sort of things they're looking at. And then there'll be a bit of post-surveillance as well. So the main thing really I wanted to talk to you guys about was the inclusion criteria, because we've got 2 patients, but there's room for more. So if you have anyone that kind of meets these criteria, and they don't have to meet all of them, essentially all you really need to know is they need to be 50, have AMD with a big Druz, and now we all know what size that is, and have like a decent area of geographic atrophy, and you don't need to measure anything, because if you just get them in, then all the other screening would be done. And there's lots of exclusion criteria, and so Marie and her team work really hard to make sure they tick all the boxes. Oh, I'm sorry, and the other thing, they have to have vision better than a 660 or better as well, and they can't be anti-vaxxers because they have to have these vaccines. So that's all I want to talk about. Sorry, it sort of dipped in and out of a few different things there, but I guess just wanted to come back to that Beekman classification and this table, which I guess if there's one thing, if all the rest of it sort of went over your heads or wasn't sort of useful day-to-day practice, I think this really would be, and helps you know who to give the AREDS vitamins to and who to worry about, and just maybe be able to tell people a bit more about their risk of AMD. That's all done. Thank you.